I'm inviting Dr. Shouvick to share his longest days, and he's our VR consultant in our Disha Eye Hospital. Dr. Shouvick, please.
Hello everyone. Hope you all are enjoying this session. Thank you Dr. Shouvick sir for giving me this opportunity. Here I am going to share you 3 of my challenging cases. Case number 1. It is a 70 years old male one-eyed pseudophakic patient present to my OPD with dimness of vision for last 6 months. Left eye there is PR inaccurate in all quadrant, and left eye there is rhegmatogenous retinal detachment with PVR D2 changes. So first I remove the all membranes and traction from the disc and the macular area meticulously. Then PFCL was introduced to stabilize the posterior pole. Then I tried peripheral vitrectomy to detach all type of vitreous adhesions. Then epiretinal membrane was removed under the PFCL very gently. Then I did fluid gas exchange and tried to drain out the peripheral fluid. But here some accidental, sorry. But during the fluid air exchange, there is a sudden entrapment of the air into the peripheral retina. It is actually denote there is a marked intrinsic traction into the peripheral retina. So I decided to do for a 180-degree retinectomy, as the air entrapment is between 180 degree. After retinectomy, I did fluid air exchange and tried to drain out the fluid. But this time I was stuck with another surprise. The free retina get rolled and flipped to the another side, and PFCL got slipped into the subretinal spaces. Actually, I underestimated the power of intrinsic traction, and that is why I did 180 degree of retinectomy. I have to do 360 degree now. But I tried to drain out the PFCL, but I was failed. I tried to manually drag the retina over its previous side, but I was failed. This time I realized there is infusion is off, and I on the infusion, and the retina is mobilized, and then I meticulously give PFCL in the right plane to stabilize the retina, and this is the that time I realized that there is a need for 360 degree RR, and I did the 360 degree RR at that time. PFCL subretinally was drained meticulously. Peripheral retina was trimmed. Then I injected more PFCL to flatten the retina. Continuous barrage laser was applied, first in continuous mode, then in repeat mode, to prevent iatrogenic tear in the latter phase. Then I did direct PFCL silicone oil exchange with 5,000 centistoke silicone oil, and I closed the cases. Post-op visual acuity after 3 weeks is 6/60, and after 3 months it is stable. Then can come to the case number 2. Here, a 70 years old male pseudophakic patient referred to my OPD for silicone oil removal and glue dial implantation in left eye. Previous history of GRT with traumatic subluxated lens was there, and he was managed efficiently by previous surgeon, and the best corrected visual acuity was 6/60 in the left eye. The retina is on under silicone oil, and there is a previous macular ERM is present. So I did the case with in the routine fashion. SFL marker, I did a scleral pocket in both sides. Then I opened the corneal incision. Is there an aphakic patient? I drained the silicone oils to the same wound with infusion line on. Then I meticulously removed the ERM from the retina. And I did a prophylactic barrage laser for safety. Then 180 degree apart 2 type of sclerotomy is introduced for extraction of the haptics. But during the insertion of the SF5L, I was suddenly noticed that there is a large globular brownish mass actually just developed sub-incisional area, and I was totally stuck with that time what is happening. I just, sorry. And I was realized that it is actually that there is accidental slippage of the infusion line going to the subretinal, the fluid going to the subretinal space, and that kind of situation can occur in our surgery, and it is a very dangerous situation for a surgeon like me. And I actually withdraw the infusion line and fit it in the another line and rise the intraocular pressure, just pray to the god the choroidal mass become settled, and hopefully and luckily I was escaped at this time and all the fluid was drained. Rest of the procedure was uneventful. The haptics was sterilized. And I check inside there is all okay, and I closed my case even applying glue. In the last case, the SFL was stable after 3 months post-op. The last case, there is a, in the next case, there is a 70 years old male, a 60 years old female patient. There is a diminution of vision for last 6 months with a best corrected visual acuity 6/60 and a history of PKP in left eye 13 years back. He is a corneal graft root cavity and all sutures are removed and pseudophakic patient. There is a large full thickness macular hole with mean hole diameter is 799 micron in the OCT. Here is the OCT picture. I started the case routinely, and PVD was induced, vitrectomy was completed. But in the when I inject the dye, there is a sudden blowout of the cornea, and this type of situation can occur in case of post PKP patient. And I just repose the iris and suture the cornea with intermittent on and off of the fluid, and not forget to tuck all the sutures. Then the situation is under my control, and then I peel the ILM. My motto is to do a inverted flap technique, and after fluid gas exchange, my case is closed, and there is a type 1 closure, and after 4 weeks post-op, the visual acuity was 6/16. Thank you so much.
Thank you, Shouvick, for a nice depiction of your complications. Dr. Reddy, please.
Yeah, the case that in which you showed is developed a brown mound
Choroidal.
while choroidal mound. If it is choroidal detachment, how come it settled so quickly after?
It is a vitrectomized eye first. So, my
So-
scleral rigidity was less that time, and there is an accidental slippage of the infusion line, and that's why the fluid actually goes inside. When I remove the cannula and trocar itself, and using the rising the intraocular pressure, the fluid gets inserted.
I think basically it was eye because extremely soft the globe collapse and may not be exactly scleral choroidal detachment. Because once a choroidal detachment happens, I mean it doesn't spontaneously settle down once you change the infusion cannula.
Actually,
to
I
the
have
opposite
seen
quadrant.
such cases of my mentor, Dr. Boral, and there is a kissing choroidals, and
Sclerotomy was angled and they are self-sealing, it will not drain the choroidal detachment.
Yeah.
But if his sclerotomies were perpendicular, once he removed the cannula, it might have drained the choroidal. Only thing which was different was it was in superior quadrant and
Good quadrant.
cannula was coming out in the
India inferior temporal.
normally it
So
comes in that
basically
quadrant only where
that case may be extreme hypotony that has caused the
choroidal fold.
folds, not exactly a detachment maybe. So
If it was suprachoroidal, it was looking like hemorrhagic choroidal detachment. You were really lucky.
Yes.
Because superiorly this kind of mound, if you see away from the infusion cannula, by first
see, choroidal detachment, they don't resolve so fast. and
Similar kind of
they don't drain
situation
so
I will
easily.
showcase in my presentation. Similar kind of situation. Just to see, it was
Excellent presentation. Dr.
Thank you, sir.
You can use the mic.
Okay.
Use two forceps to reposit the retina. Then retina curls back on a posterior plane.
Okay.
Keep it there for some time, then it sticks. Otherwise, it keeps falling back.
Actually, I didn't go for 360 retinectomy, and that kind of traction.
Because at that stage he was under air. The eye was, it was under air.
Yeah.
He had to make the infusion on again. Then only you can just reposit. Otherwise,
You need not switch on the infusion.
if you do the, yes.
Okay.
And you just make the relaxing incisions on the sides. And then pull with two forceps, with chandelier. Keep it there for some time, it's stuck.
Okay.
Otherwise, it keeps coming back.
Okay, sir. Thank you for your suggestion.
Thank you, Deepander. So I am sharing my